Good morning. So, your class today is on adrenergic drugs. Adrenergic drugs are the drugs that mimic sympathomimetic action, the action that is produced by sympathetic system stimulation. Okay. Now, adrenergic, more precisely noradrenergic, because the most important neurotransmitter in the sympathetic system is noradrenaline. So, adrenergic, more precisely noradrenergic transmission is restricted only to the sympathetic system of the autonomic nervous system. There are three endogenous catecholamines. The catecholamines are the basically messengers synthesized in the body and that are related to the adrenergic sympathetic nervous system. These are noradrenaline, adrenaline and dopamine. Noradrenaline, it acts as the neurotransmitter at the postganglionic sympathetic site and in certain areas of brain. আচ্ছা, পোস্ট গ্যাংলিয়নিক সিম্প্যাথেটিক সাইটে কি ট্রান্সমিটার থাকে হতে পারে? পোস্ট গ্যাংলিয়নিক সিম্প্যাথেটিক সাইটে not receptor, neurotransmitter. Maximally that is noradrenaline, but acetylcholine may be there in certain cases, like in certain blood vessels and in the sweat gland. So noradrenaline, it acts as a transmitter at the postganglionic sympathetic site and in certain areas of the brain. Adrenaline, it is secreted at the adrenal medulla. It is secreted by the adrenal medulla and may have a transmitter role in the brain. Dopamine, it is a major transmitter in basal ganglia, limbic system, chemoreceptor trigger zone, anterior pituitary. Now, coming to the synthesis of catecholamines. Catecholamine is synthesized from an amino acid phenylalanine. Phenylalanine in the liver, it is basically converted to tyrosine by the enzyme hydroxylase. Now this tyrosine enters the adrenergic nerve cytoplasm and is metabolized or it converted to dopa by again the tyrosine hydroxylase. This is a rate limiting enzyme in the synthesis of catecholamines, and this enzyme tyrosine hydroxylase is inhibited by the drug alpha-methyl-tyrosine. Now there is a condition or a disease called Pheochromocytoma, where the endogenous catecholamine synthesis in the body is abnormally increased. Now to decrease the synthesis of catecholamines there, the drug is used alpha-methyl-tyrosine. So this inhibitor can be used in Pheochromocytoma before surgery and in inoperable cases to decrease the endogenous synthesis of catecholamines. Now, after the synthesis of dopa is taken up, dopa is converted to dopamine in the adrenergic neuronal cytoplasm by the enzyme dopa decarboxylase. Then again to the noradrenal, dopamine is taken up by the vesicles in the axonal cytoplasm called granules. Now after taking up, dopamine is converted to noradrenaline and by the enzyme beta hydroxylase. There it stops, but in adrenal medulla this noradrenaline is converted to adrenaline by the enzyme N-methyltransferase. These are all non-specific enzymes. They are involved in other metabolisms also, but tyrosine hydroxylase is a specific enzyme, is a rate limiting enzyme in the synthesis of catecholamines. Now this is a schematic diagram showing the synthesis, storage, release, uptake and metabolism of catecholamines. Now you see here, this is a tyrosine converted from the phenylalanine in the liver. Now it is taken up by the adrenergic nerve in the cytoplasm, and tyrosine is converted to DOPA by the enzyme tyrosine hydroxylase. Now, this tyrosine hydroxylase is inhibited by alpha-methyl-tyrosine. Basically it is a drug that is used in Pheochromocytoma. Now, DOPA is converted to dopamine in the cytoplasm by the enzyme DOPA decarboxylase. This dopamine is taken up by the vesicles in the adrenergic neurons and converted to noradrenaline by the noradrenaline. Now, this noradrenaline is kept stored in the vesicles by binding to ATP in a ratio of 4:1, and that get absorbed in the protein. Now, when adrenergic nerve is stimulated by a nerve impulse, then what happens? This stored noradrenaline is released from the adrenergic neuron, okay, by exocytosis, that is helped by calcium. So, noradrenaline is released from the vesicles by exocytosis in the junction, in the synapse, where noradrenaline is free to act on the post effector organ or effector cell. Now, after the action is over, noradrenaline is taken up by the transporter norepinephrine transporter, NET, actively, and this transporter is responsible for the termination of action of norepinephrine around 70 to 80%. Now, after it is taken up, noradrenaline, it can again stored in the vesicles, or the noradrenaline can be metabolized in the adrenergic neuronal cytoplasm by the enzyme MAO, monoamine oxidase, and in the tissues, in the synapse by the enzyme COMT, catecholamine-O-methyltransferase. These are the two enzymes. MAO is basically located in the adrenergic neuronal cytoplasm, and COMT is located in the tissues. So, these are the enzymes that is responsible for the metabolism of the noradrenaline. Now, what happens? This noradrenaline is metabolized by the monoamine oxidase MAO inhibitors or COMT to Vanillylmandelic acid, and there can be other products also in a smaller quantity, normetanephrine, metanephrine and others. The two products are produced in larger quantity, that are Vanillylmandelic acid and basically is the major product VMA, and that is either sulfated or glucuronidated and basically excreted from the body. Now, in the patient of Pheochromocytoma, these byproducts of the noradrenaline is increase in urine, and that is a marker for diagnosis of Pheochromocytoma. Now, what happens? This we discussed that alpha-methyl-tyrosine is an inhibitor of tyrosine hydroxylase. Now, again, this norepinephrine transporter that is involved in the taking up of noradrenaline from the synapse in the prejunctional neuron, that is inhibited by cocaine, desipramine and certain other drugs, and that basically increases the sympathetic neuronal activity by increasing the concentration of noradrenaline at the synapse. Again, tyramine is an indirect sympathomimetic, because tyramine when tyramine is given, it get entry into the adrenergic neuronal cytoplasm and noradrenaline is released, but that is not calcium dependent, unlike via exocytosis, and that also increases the sympathetic activity. Now, coming to the adrenergic receptors, you have all known about different type of receptors in your pharmacokinetic classes. Now, these adrenergic receptors are G protein coupled receptors. It can be GS type what the second messenger in the GS protein coupled receptor? CAMP. CAMP is increased. It can be GQ type. GQ কি করে second messenger? কে বল next অন্য কেউ? GQ protein coupled receptor second messenger. IP3 DAG pathway. ঠিক আছে? It can be GS type, it can be GQ type, it can be GI type, it can be GO type. Now adrenergic receptors are membrane bound G protein coupled receptors which function primarily by increasing or decreasing the intracellular production of second messengers CAMP or IP3 DAG pathway. Adrenergic receptors are of two types, alpha and beta. These were basically the classification was given by Alquist. He was an American pharmacist and pharmacologist. So adrenergic receptors are classified into alpha receptor type and beta receptor type. Now coming to the alpha receptor type, adrenaline action is more or equal to noradrenaline followed by noradrenaline, and isoprenaline has got least action on the alpha receptor. Beta receptor, isoprenaline has got major action followed by adrenaline followed by noradrenaline. Antagonist phenoxybenzaimine is an antagonist of alpha receptor. Alpha receptor can be again alpha 1 receptor, alpha 2 receptor, and phenoxybenzaimine is a non-specific alpha receptor blocker. Propranolol is antagonizes beta receptor. Beta receptor can be again beta 1 receptor, beta 2 receptor, and beta 3 receptor have been recently found out present in the adipose tissue. Propranolol not specifically inhibit beta 1 and beta 2 receptor. Now alpha receptor is either GQ, GI or GO type depending on alpha 1 or alpha 2, and beta is GS type. So it increases cyclic AMP. Effector pathway, if it is by GQ protein coupled receptor, it increases IP3 and DAG. If it is by GI type, it decreases cyclic AMP, or GO type, it increases the potassium channel conductance, potassium conductance through the channel. Now, so we discussed that alpha receptor can be alpha 1, can be alpha 2. Now, where are they located? Alpha 1 is located post-junctionally on the effector organ. Alpha 2 is predominantly located in the pre-junctional membrane, neuronal membrane. সাইন্যাপসের আগে যেটা নিউরন থাকে যেটাকে প্রি-জাংশনাল নিউরন বলা হয়। নর্মালি কি হয়, noradrenaline is acting on the post-junctional neuron after getting released from the pre-junctional neuron. Now alpha 2 receptor is located on the membrane of pre-junctional neuron, and when the noradrenaline act there, it inhibit the release of noradrenaline from the pre-junctional neuron, and thus it is responsible for decreasing central sympathetic outflow. So pre-junctional neuron on the nerve ending, also post-junctional in certain areas like brain and pancreatic beta cells, and extrajunctional. Extrajunctional মানে যেখানে কোনো নিউরোনাল অ্যাক্টিভিটি নেই, ঠিক আছে? Extrajunctional in the blood vessels, in the platelets. So in the blood vessels, alpha 2 action occurs because of circulating catecholamines, not because of neuronally released noradrenaline. Now functions, due to alpha 1 action in the genitourinary smooth muscle, it will cause contraction. In the blood vessels, both alpha 1 alpha 2 causes vasoconstriction, while beta causes vasodilatation. Okay, so vasoconstriction in both the cases, gland secretion, gastrointestinal tract relaxation. In the liver, it causes glycogenolysis and hence hyperglycemia. In the heart, it increases the heart, it causes arrhythmia. Now inhibition of transmitter release via alpha 2 because of activation of alpha 2 on the pre-junctional neuron. It can cause vasoconstriction, decreased central sympathetic outflow, decreased insulin release because alpha 2 are also present on the pancreatic beta cells. Causes platelet aggregation because of presence of platelet. Now selective agonist alpha 1, it can be phenylephrine methoxamine. Alpha 2 selective agonist clonidine. Okay, এগুলো মুখস্থ করতে হবে। Selective antagonist alpha 1 prazosin, while alpha 2 yohimbine rolsin. Coupling protein, কোন protein coupled receptor আছে? Alpha 1 is GQ type, so it is increasing IP3 and DAG, while alpha 2 can be again GI type or GO type. So GI type, it decreases the cyclic AMP, and basically GO type, it increases the potassium channel conductance, it decreases calcium channel conductance. Okay. Now coming to the beta receptors. Beta receptors can be beta 1, can be beta 2, can be beta 3. Beta 1 located in the heart. হার্টে একটাই অ্যাড্রেনার্জিক রিসেপ্টর আছে, দ্যাট ইজ বিটা 1, ঠিক আছে, নো অ্যালফা। সো হার্টে বিটা 1 অ্যান্ড অলসো ইন দ্য কিডনি juxtaglomerular cells it is located বিটা 1. বিটা 2 কোথায় আছে? ব্রঙ্কাসে রয়েছে, জেনিটো ইউরিনারি ট্র্যাক্টে আছে, গ্যাস্ট্রোইন্টেস্টিনাল ট্র্যাক্টে আছে, ইউটেরাসে, লিভারে, ব্লাড ভেসেলস, ইউরিনারি ট্র্যাক্ট, আই। বিটা 3 অ্যাডিপোজ টিস্যু। Okay, so beta 1 কোথায়? In the heart and in the juxtaglomerular cells of kidney. Beta 3 adipose tissue and others beta 2 যে কোনো স্মুথ মাসলে, visceral, bronchus, genitourinary tract, gastrointestinal tract, uterus, even in eye. Selective agonist of beta 1 dobutamine. For beta 2 is salbutamol terbutaline, and beta 1 beta 3 basically is an investigational drug. Selective antagonist metoprolol, atenolol, and for beta 2 is alpha-methyl-propranolol. Coming to the adrenergic drugs, also called sympathomimetics, because their action basically mimics the sympathetic nerve stimulation. So they are also called sympathomimetic. They can be direct sympathomimetics, they can be indirect sympathomimetics, they can be of mixed action. Direct মানে কি? These drugs, they directly act on the adrenergic receptors and produce responses similar to that of sympathetic nerve stimulation. Examples are adrenaline, noradrenaline, isoprenaline, phenylephrine, xylometazoline, salbutamol and others. Indirect sympathomimetics, they are not directly acting on the receptors. They increases, basically they act on the adrenergic neuron to release the catecholamines, and thus they are increasing the sympathetic activity. So they act on adrenergic neuron to release noradrenaline, which then act on the adrenoceptors. Examples, tyramine, we have learnt tyramine, they basically increases the release of norepinephrine via acting on the norepinephrine transporter. Amphetamine. What about mixed action? They act directly as well as indirectly, like ephedrine, dopamine, methamphetamine. Now, very important table, adrenaline. Adrenaline has got alpha 1, alpha 2, beta 1, beta 2, but very weak beta 3 action. While noradrenaline, they have got alpha 1, alpha 2, beta 1, beta 3, but very weak or no beta 2 activity. Isoprenaline, they have got no alpha action, they have got only beta 1, beta 2, beta 3 action. Now coming to the actions of adrenergic drugs on each organ. Number 1 on the heart. তো হার্টে কোন রিসেপ্টর আছে? বিটা 1 রিসেপ্টর আছে, তাই তো? So, beta 1 receptor stimulation will cause increase in the heart rate. আমরা কার্ডিয়াক অ্যাকশন পোটেনশিয়াল দেখেছি, তাতে তাতে কি হয়, কি ফেজ আছে, ফেজ 0, ফেজ 1, ফেজ 2, ফেজ 3, ফেজ 4. আর এই ফেজ 4টা in case of pacemaker cells that show a diastolic depolarization, right. Now this slope, the slope of diastolic depolarization in the SA nodal cells, that is increased. As a result, there is increase in the heart rate. So it increases heart rate by increasing the slope of the slow diastolic depolarization of cells in the SA node. Number 1 action. Number 2, it activates the latent pacemakers in the AV node, in the Purkinje fibers. Same action, same cause. Number 3, arrhythmias can occur with high doses that raises BP markedly. Can? Because of sudden rise in blood pressure. Because of sudden rise in blood pressure, there is reflex bradycardia because of vagal nerve stimulation. Now, due to bradycardia, the SA nodal due to the SA nodal suppression, there is bradycardia. The latent pacemaker will take up because already the latent pacemakers have been activated by the adrenaline or catecholamines. So there is basically chances of arrhythmia. Raised BP reflexly depress AC node and unmask the latent pacemakers. So it all about the heart rate. Then force of contraction of the heart is increased because of beta 1 action. So force of cardiac contraction is increased. As a result, cardiac output is increased. That is responsible for increase in systolic blood pressure, and oxygen consumption of heart is increased. Number 3, conduction velocity via the AV node, via the bundle of His and the ventricular fibers is also increased, and that can take care of the partial AV block. All cardiac actions are predominantly beta 1 receptor mediated. Beta 1 receptor কি টাইপ অফ রিসেপ্টর আছে, beta 1 receptor কি টাইপ অফ রিসেপ্টর আছে, GH type. All beta receptors are GH type protein coupled receptors. So all cardiac actions are predominantly beta 1 receptor mediated. When BP rises markedly, particularly after intravenous injection of the noradrenaline, noradrenaline has got no beta 2 action, and beta 2 on the blood vessel cause vasodilatation that causes fall in the diastolic blood pressure. But as there is no beta 2 action, there is no vasodilatation, there is no fall in diastolic blood pressure with noradrenaline compared to adrenaline. So when noradrenaline is injected IV, BP rises markedly and reflex bradycardia is seen due to stimulation of vagus nerve. That is not seen with adrenaline injection. That is only seen with noradrenaline injection, right? Reflex bradycardia. Now coming to the action of adrenergic drugs on the blood vessels. Blood vessels have got alpha receptors, alpha 1 and alpha 2 as well. Alpha 1 is located basically neuronally mediated, is junctional receptor, while the alpha 2 receptor is extra junctional, and that is stimulated by the circulating catecholamines. And there is also beta 2 receptors. Beta alpha receptor cause vasoconstriction and beta 2 receptor cause vasodilatation. Now what will happen, that depend on the site where it is acting. Okay, so the action is most marked on the arterioles and the capillary sphincters. Now where is the predominant vasoconstriction? These are seen in the cutaneous, mucous membrane and renal beds. So vasoconstriction are predominantly seen in the mucous membrane, in the skin blood, cutaneous blood vessels and in the renal vasculature. Vasoconstriction occurs through both alpha 1 and alpha 2 receptors. However, location of alpha 2, that is extrajunctional, is such that they are activated only by circulating catecholamines, whereas alpha 1, that is junctional receptor, primarily mediate response to the neuronally released noradrenaline. Vasodilatation কোথায় পাই আমরা? In the skeletal muscle, in the liver and in the coronaries. No significant action on the cerebral blood vessels. Now, noradrenaline, they cause rise in systolic blood pressure, in diastolic blood pressure and the mean blood pressure. যদি সিস্টোলিক ডায়াস্টোলিক দুটো রাইজ করবে তাহলে মিন ব্লাড প্রেশার রাইজ করবে। হ্যাঁ, সিস্টোলিক ব্লাড প্রেশার কেন রাইজ করছে? বিকজ অফ বিটা 1 অ্যাকশন, নাম্বার 1 beta 1 action, number 2 because of alpha action, it is causing vasoconstriction. Okay, so rise in systolic blood pressure is due to basically beta 1 action. In the diastolic blood pressure is due to alpha action. Alpha action is causing vasoconstriction, that is increasing peripheral resistance, and that is responsible for rise in diastolic blood pressure. It does not cause vasodilatation unlike adrenaline, because adrenaline has got also beta 2 action, and beta 2 receptor stimulation causes vasodilatation. Okay, so it does not cause vasodilatation, no beta 2 action, peripheral resistance increases consistently due to the alpha action. Now coming to the isoprenaline, isoprenaline has got only beta 1, beta 2, beta 3 action, no alpha action. So there will be only vasodilatation, and beta 1 stimulation causes rise in systolic blood pressure. So isoprenaline will cause rise in systolic blood pressure, fall in diastolic blood pressure because of fall in peripheral resistance, and the mean arterial blood pressure will fall. So isoprenaline causes rise in systolic but marked fall in diastolic blood pressure. Beta 1 cardiac stimulation, beta 2 vasodilatation. Adrenaline, either given by slow IV infusion or subcutaneously, will cause rise in systolic because of beta 1 action and fall in diastolic blood pressure, okay, because of beta action. Peripheral resistance decreases because vascular beta 2 receptors, as said earlier, are more sensitive to the adrenaline than the alpha receptors. So there is rise in systolic blood pressure and fall in diastolic blood pressure, but the mean blood pressure is higher, rises. Mean blood pressure generally rises and the pulse pressure is increased. Now, very important concept here, rapid IV injection of adrenaline, what does it cause? Generally, when a significant amount of adrenaline is injected intravenously, at first that will cause rise in mean blood pressure, okay, because of alpha action and beta 1 action. Now what happens after that, as the concentration of adrenaline begins to fall, what will happen? The blood pressure, mean blood pressure will start to fall. Now at one time the concentration of the adrenaline in the blood decreases to a significant level, and the beta receptors are they are more sensitive to the adrenaline than the alpha receptors. So when the concentration of the adrenaline falls in the blood, what will happen? There will be fall in blood pressure because of beta 2 action, and then gradually the blood pressure normalizes. This is a normal response of the mean arterial blood pressure by rapid IV injection of adrenaline. Okay, now what happens if prior to administration of adrenaline, if we push an alpha blocker here, if we give an alpha blocker, that will block the alpha receptor. Okay, after some time we again give an injection we give adrenaline injection intravenously, then what will happen? There is no rise in blood pressure because alpha action is absent. There will be mostly fall in blood pressure because of beta action, and this phenomenon is called vasomotor reversal of Dale. ঠিক আছে? So Rapid IV injection of adrenaline in animals produces a marked increase in both systolic as well as diastolic blood pressure, because at high concentration alpha response predominates and their vasoconstriction is seen. The BP returns to normal within a few minutes and a secondary fall in mean BP follows, because at lower concentration beta receptors are more sensitive to adrenaline. The mechanism is rapid uptake and dissipation of adrenaline. Concentration around the receptor is reduced. Low concentrations are not able to act on alpha receptor but are able to act on the beta 2 receptors. When an alpha blocker has been given, only fall in BP is noted and that is known as vasomotor reversal of Dale. ठीक है, बुझा गया এটা খুব ইম্পর্টেন্ট কোশ্চেন রয়েছে। Now action of adrenergic drugs on the respiration. We know beta 2 receptors are present on the bronchus and that is responsible for bronchodilation. Okay, so adrenaline and isoprenaline but not noradrenaline. Can nahi? Because no beta 2 action. So adrenaline and isoprenaline but not noradrenaline, they are potent bronchodilators because of beta 2 action. The action is more marked when the bronchus is constricted. Now adrenaline given by aerosol additionally decongest bronchial mucosa by alpha action, vasoconstriction kore. Now there is an important question, why adrenaline is preferred in anaphylactic shock but not adrenaline, but not noradrenaline. It's an important question in YY and it may come even in the question paper. This is because in anaphylactic shock, other than shock, there is bronchoconstriction. Now when noradrenaline is given, it will cause basically vasoconstriction and that will raise the blood pressure definitely, but it has got no beta 2 action, so bronchoconstriction will not be taken care of. But adrenaline, they have got additionally beta 2 action, so they also dilate the bronchus and take care of that part also. So adrenaline is preferred, is the drug of choice in the anaphylactic shock, not the noradrenaline. Now action of adrenergic drugs on the eye. On the eye, number 1, it causes mydriasis. Number 2, it causes fall in intraocular pressure and is useful in glaucoma patient, open angle glaucoma. Now mydriasis occurs due to the contraction of radial muscles of the iris. Iris e two type of muscle thake. These are radial muscles and these are constrictor muscles. Now these adrenergic drugs, they act on the radial muscles, cause contraction, that is responsible for mydriasis and that is alpha 1 receptor mediated. But this action is minimal after topical application. Why? Because adrenaline penetration of cornea is poor. Now aqueous formation is reduced and outflow is facilitated, that causes fall in intraocular pressure and hence adrenergic drugs find role in open angle glaucoma. Now what are the receptors that are acting? Alpha 1 receptor, they are present on the ciliary vessels causing vasoconstriction and there is reduced aqueous humor formation. Alpha 2 they are present in the ciliary epithelium and they cause reduced secretory activity, hence decreased aqueous humor formation. Beta 2 action, they facilitate trabecular outflow. On the GIT, peristalsis is reduced, sphincters are constricted, but the action is minimal or brief and of no clinical importance in human being. Now, on the bladder, it causes retention of urine or it holds endomicturition. Why? Because of relaxation of detrusor muscle, beta 2 action and via constriction of the trigone muscles, alpha action, alpha 1 action better to say. Now Action of adrenergic drugs on the uterus. Now, adrenaline can cause both contraction and relaxation of uterus respectively through alpha and beta receptors. In the human uterus, adrenaline causes relaxation at the term of pregnancy, but in other states it causes contraction. Now, on the splenic capsule, it contracts the splenic capsule, more RBCs are poured in the circulation, but not of clinical importance in human beings. Now, on the skeletal muscles, basically the postganglionic neurotransmitter is acetylcholine. Now, neuromuscular transmission is facilitated here because in contrast to action on autonomic nerve endings, alpha receptor activation on motor nerve endings augment acetylcholine release, and that facilitates neuromuscular transmission. Now, the direct effect on muscle fiber depends on the type of fiber that is activated. It can be slowly contracting red fibers, it can be rapidly contracting white fibers. Via action on the slowly acting contracting red fibers, it produces tremors due to beta 2 receptor stimulation. And why? Because the active state, because it increases the force of contraction and it also decreases the refractory period. So, the two responses there is incomplete overlapping, and that is responsible for the tremor. The action on the rapidly contracting white fiber is to prolong the active state of contraction and increases the tension developed. On the central nervous system, generally no significant response is seen because adrenaline do not cross the blood-brain barrier because of poor penetration in brain, but restlessness, apprehension and tremor may occur. Activation of alpha 2 receptor in the brain stem can decrease the sympathetic outflow by action of selective alpha 2 agonist. Then there will be fall in blood pressure and bradycardia seen by clonidine. It is an alpha 2 receptor agonist. Metabolic action, adrenaline causes glycogenolysis in the liver and in the muscles. So, in the liver via glycogenolysis there is hyperglycemia, and in the muscle it causes hyperlactacidemia. Lactic acid production is increased. Now, in the fatty tissue it causes breakdown in the fatty tissue, causing rise in plasma free fatty acid level, and because of that there is increased calories in the body, causing calorigenesis. These are mediated by beta 2 beta 3 action in the adipose tissue and via beta 2 action in the liver and skeletal muscles. In addition, there is reduction of insulin secretion from the pancreatic beta cells, alpha 2 action, and there is glucagon secretion is augmented by beta 2 action, that again lead to hyperglycemia. Now, there may be transient hyperkalemia followed by hypokalemia. Why there is transient hyperkalemia? Because of initial release of potassium from the liver cells. And why there is followed by hypokalemia? Because there is followed by the increased uptake of potassium in liver and in the skeletal muscles. These are all about the basically adrenergic drugs. So, distribution আমরা পড়েছিলাম, factors affecting distribution of drugs. Now, coming to apparent volume of distribution, it is a very important concept in pharmacokinetics. Now, say this is a human body, okay, and there is uniform tissue fluid distribution here. Now, there is a blood vessel where a drug is injected. Drug is injected is 1000 milligram of the drug is given. Okay? And what happens after injecting the drug 1000 milligram, we wait for some time and take the plasma concentration from the blood, and we are getting 50 milligram per liter. If there is uniform tissue fluid in the body, then we are getting 50 milligram per liter concentration and 1000 milligram of drug was injected. We can find out in what volume the drug has been distributed via the formula dose administered IV by plasma concentration. Okay? And this gives us the value for apparent volume of distribution. Why apparent? This is because we have considered that the tissues in which the drug has been distributed is uniform, but it is not so. Body is multi-compartmental, it is not unicompartmental. But to understand the pharmacokinetics of the drug, we made it simpler, and so it is apparent volume of distribution. And taking this concept, understanding of different pharmacokinetic properties of a drug, it becomes easier to us. We will come to it. So, an apparent volume of distribution can be defined as the volume that would accommodate all the drug in the body if the concentration throughout was the same as in plasma. বোঝা গেছে? Presuming that the body behaves as a single homogeneous compartment with volume V into which the drug gets immediately and uniformly distributed. V, that is volume of the apparent volume of distribution, is equal to dose administered IV by plasma concentration. Now, liquid insoluble drugs, they do not enter the cells, and hence V approximates extracellular fluid volume. আমরা জানি বডিতে vascular fluid আছে, extravascular fluid আছে, plus তোমার intracellular fluid আছে, এই তো? Now, lipid insoluble drugs, they are not entering the cells, so they are mostly located in the vascular and extravascular fluid. So, it do not enter the cells. V approximates extracellular fluid volume like gentamicin, streptomycin. Volume of distribution comes around 0.25 liter per kg. Drugs that are extensively plasma protein bound. We know ACD drugs bind more to the albumin, and the basic drugs bind more to the alpha acid glycoprotein. So, drugs extensively bound to plasma proteins are largely restricted to the vascular compartment, and their volume of distribution is still lower. For example, diclofenac warfarin 0.15 liter per kg. Certain drugs are sequestrated in a specific tissues like chloroquine in the retina. So, there the volume of distribution is much higher. In case of poisoning, drugs with large volume of distribution are not easily removed by hemodialysis. That is the clinical implication. Pathological states, for example congestive heart failure, uremia, cirrhosis of liver, can alter the volume of distribution of many drugs by altering distribution of body water, permeability of membrane, binding proteins, or by accumulation of metabolites that displace drug from binding sites. Redistribution is another important concept. The clause is the drug should be highly lipid soluble, and number 2, that action of drug should be in the highly vascular organ. Now, if a highly lipid soluble drug is injected intravenously, what will happen? The drug will first get distributed in the highly vascular tissues, because সেখানে blood supply more আছে, যে কোনো drug হবে, that include brain, kidney and the heart. Then after that, the drug will be gradually distributed in these low vascular tissues, bulky tissues like muscles and others. So, highly lipid soluble drugs get initially distributed to organs with high blood flow like brain, heart, kidney. Later, less vascular tissues but more bulky tissues like muscle and fat take up the drug. Now, after the bulky tissues are taking up drugs, the drug concentration falls in the highly vascular organ. Okay. So plasma concentration falls and the drug is withdrawn from the highly perfused site like brain, kidney, heart. If the site of action of drug, if the primary site of action of drug is in the highly perfused organ like brain, what will happen? As the concentration will fall there, the action terminates, although the drug is present in the body. Okay. Greater the lipid solubility of drug, faster will be the redistribution. Now, that is why thiopentone sodium is a basically general anesthetic drug. It is very ultra short acting because it is highly lipid soluble and it acts on the brain, which is highly vascular organ. So when the drug is injected intravenously, it gets rapidly distributed in the brain, the action starts, gradually the drug is taken by the lesser vascular tissues and the action stops. So anesthetic action of thiopentone sodium injected intravenously is terminated in few minutes due to redistribution. বোঝা গেছে? A relatively shorter hypnotic action of lasting 6 to 8 hours with oral diazepam because of redistribution. Blood brain barrier, brain and CSF. এখানে দুটো ব্যারিয়ার থাকে, blood brain barrier, blood CSF barrier, that is formed by the tight cellular junctions, and these are reinforced by the neuronal tissues. Additionally, they are active, the junction is tight, plus there are efflux transporters in the blood brain barrier, in the blood CSF barrier, that include P glycoprotein and that include organic cation transporters, and that limit the entry of drugs in the brain, and that help us with the harmful effect of xenobiotics. So both these barriers are lipoidal, they limit the entry of non-lipid soluble drugs. Again, there are efflux transporters like P glycoprotein, OATP, that limit the entry of drugs in the brain. Again, dopamine basically is helpful in Parkinsonism patient, but problem is that dopamine cannot enter the blood brain barrier, cross the blood brain barrier. So we do not give dopamine in Parkinsonism patient, we give levodopa. Levodopa is a prodrug. Now this drug can easily cross the blood brain barrier and reaching the brain, it is converted to dopamine and is there for the action. So levodopa is used in Parkinsonism patient, not dopamine. বোঝা গেছে? Now, inflammation of meninges of brain increases permeability of barriers. Passage across placenta, again it is also a barrier that prevents the entry of drugs to the baby because of presence of tight intracellular junctions, and there are also efflux transporters, P glycoprotein, BRCP, MRP3, but it is an incomplete barrier because there are some influx transporters also, so it is an incomplete barrier. Plasma protein bindings, certain drugs are extensively plasma protein bound. Acidic drugs bind to the albumin, basic drugs bind to the alpha-1 acid glycoprotein. These are the list of the drugs. Now, clinical implication of plasma protein binding. Number one, highly plasma protein bound drugs. They are largely restricted to the vascular compartment, so volume of distribution will be low. Okay? The bound fraction is not available for action. It acts as a temporary storage of drugs. When the free drug is used, the bound drug dissociates from the storage and it is used for the action again. High degree of plasma protein binding generally makes the drug longer acting. Now, by the concentration of drug in the body, we mean concentration of free and bound drugs both. One drug can bind to many sites on the albumin molecule, and again many drugs can bind to the same site, and this causes displacement reaction. Example, aspirin displaces sulfonylurea, both bind to the albumin at the same site. So when both drugs are given, the concentration of one drug becomes higher. In hypoalbuminemia, binding may be reduced because of low albumin level, and hence the free drug concentration rises. Tissue storage, certain drugs accumulate in certain tissues predominantly, and that is responsible for large volume of distribution. Some even exert local toxicity. Now these are the certain drugs like digoxin, emetine, they are sequestrated in skeletal muscle heart, digoxin chloroquine in the kidney, iodine in the thyroid causing thyrotoxicity, retinate chloroquine, so chloroquine causes retinal damage যদি বেশি দিন দেওয়া হয়, ephedrine atropine on the iris, tetracyclines on the bone and teeth, they degenerate the bone and teeth, adipose tissue thiopentone, minocycline and others. Okay.